Chapter 57, the assessment of the renal urinary system. The priority concept in this chapter is elimination. The main focus is on the renal system's role in eliminating waste from the body via urine formation and excretion. The interrelated concepts in this chapter are fluid and electrolyte balance, acid-base balance. These are closely tied to the kidney function as the kidneys regulate fluid volume, electrolytes, and pH balance. Renal system overview. The renal system overview, the function of the renal system. It eliminates waste, maintains fluid and electrolyte and acid-base balance, regulates blood pressure, produces erythropoietin for RBC production, and activates vitamin D. On this slide, you will see the organs of the renal and urinary system, where they're located. And that is a note at the bottom that says, as noted in the figure above, the organs of the renal urinary system include the inferior vena cava, the adrenal glands, renal vein, iliac crest, uterus, kidneys, renal artery, abdominal aorta, ureter, sigmoid colon, urinary bladder, and the urethra. Kidney anatomy, location and structure. Two kidneys located retrooperatively. The left is slightly longer, surrounded by fibrous capsule, fat, and connective tissue. Key internal parts: cortex, the medulla, pyramids, papillae, calyces, and renal pelvis. The kidney blood supply receives 600 to 13 milliliters per minute of blood via the renal artery. Blood is filtered in the nephrons, then returned via the renal vein. The nephrons has two types: cortical nephrons, which is short in cortex, and jugular medullary nephrons. They're longer and extend deep into the medulla. Concentrated urine. Structure starts at the Bowman capsule to the proximal convoluted tubule, then to the loop of Henle, descending and ascending limbs, then to distal convoluted tubule, and then to the collecting duct. The blood flow through the nephrons: afferent, AFFERENT, arterioli, to the glomerulus, and then the efferent, EFFERENT, arterioli, and then to the peritubular capillaries or the vas recta. Juxtaglomerular complex, specialized cells in the afferent and efferent arterioles and the distal convoluted tubule, DCT, releases renin, RENIN, in response to low blood pressure, low volume, and low sodium. Renin then triggers the RAAS, which is the renin angiotensin aldosterone system, to increase sodium and water reabsorption, to increase blood pressure and volume, to increase the potassium to excrete from the body. Overview of the kidney function. The kidneys perform both regulatory and hormonal functions. The regulatory functions start with the glomerular filtration. There are three barrier layers: endothelium, basement membrane, and epithelium. Only small particles such as electrolytes and glucose and urea pass through. Large proteins or blood cells should not pass. If present in urine, report it to the doctor immediately. Glomerular filtration. The first step in urine formation filters water and small solutes from the blood into the Bowman's capsule. Normal GFR is 120 milliliters per minute, which leads to about 180 liters a day. Only 1 to 3 liter becomes urine. The GFR is self-regulated by blood flow and arteriole diameter. Tubular reabsorption returns 99% of the filtered water to the blood. Most reabsorption occurs in the proximal convoluted tubule. PCT is the abbreviation. The ADH and aldosterone regulates reabsorption in the distal convoluted tubule. DCT is the abbreviation, and the collecting ducts. Glucose is reabsorbed unless blood glucose is greater than 180 milligrams per deciliter. Then you have tubular secretion. Moves substance such as potassium and hydrogen from the blood into urine to maintain the pH and electrolyte balance. Hormonal functions. Renin is released by the juxtaglomerular complex when the blood pressure, the blood volume, or the sodium is low. It triggers the RAAS to increase aldosterone, which leads to an increase in sodium and water reabsorption, which leads to an increase in blood pressure and blood volume. Erythropoietin stimulates red blood cell production, RBCs, in bone marrow when oxygen is low. Activated vitamin D converts to active form in kidneys, which is essential for calcium absorption and bone health. Prostaglandins regulate the GFR, vascular resistance, and sodium water excretion. Safety alert. Glucose or protein in urine is an abnormal finding and must be reported. May indicate diabetes or renal damage. Electrolyte reabsorption highlights. Sodium, chloride, and water, mostly in the PCT, also in the collecting duct, regulated by aldosterone. Potassium will reabsorb in the PCT and the thick ascending loop. Calcium and phosphate, mostly reabsorbed in the PCT, regulated by PTH and calcitonin. Bicarbonate helps maintain blood pH. Urinary tract structures and functions. The ureters function: transportation of urine from kidneys, renal, pelvis to bladder. Size 12 to 18 inches, which is 30 to 45 centimeters long. A half an inch, which is 1.25 centimeters wide. Narrowing points: the ureter pelvic junction, where renal pelvis becomes the ureter. Artiliac bend, as the ureter crosses over the iliac vessel. Ureterovascular junction, where the ureter enters the bladder. Structure: the inner mucosal lining, the urothelium, the middle smooth muscles for peristalsis, the outer fibrous layer. Urine movement regulated by stretch receptors and peristaltic contractions. Urinary bladder function: stores urine, maintains continence, and allows voluntary voiding. Location: males in front of the rectum, females in front of the vagina. Parts: bladder body, sac, and the bladder neck, posterior urethra. Layers: the inner urothelium, the middle, the detrusor muscle, smooth muscle, the outer, connective tissue. Trigone is a triangular area between the urethral opening and a urethra. Sphincters: internal urethral sphincter, smooth muscle of the bladder neck. External urethral sphincter, skeletal muscle, controlled by pudendal nerve. Males is around the prostate and females is at the bladder base. Voiding: micturition, reflex involving the detrusor contraction, relaxation of the pelvic floor muscle and the external sphincter. Controlled voluntarily by the cerebral cortex and the brainstem. Sympathetic nerves prevent detrusor contraction during filling. Continence maintained through muscle tone, nerve function, and mucosal adhesion. Urethra function: allows urine to exit from bladder. Structure: is lined with mucosal membrane, ends in the urethral meatus. Male urethra is about 6 to 8 inches, which is 15 to 20 centimeters. The prostatic urethra through the prostate. The membranous urethra, which is at the pelvic floor of the male. And the cavernous, cavernos urethra through the penis. The female urethra is from 1 to 1.5 inches, which is only 2.5 to 3.75 centimeters. The meatus located below the clitoris in front of the vagina and rectum. Kidney and urinary changes associated with aging. Kidney changes: reduced corticoid tissue and nephrons leads to kidneys getting smaller. Decreased renal blood flow 10% per decade. Lower GFR 65 milliliters per minute by the age 65. Thickened glomerular tubular linings, which leads to decreased filtration and waste excretion. Tubular function declines, leads to decreased urine concentration, and leads to nocturia and urgency. Impaired thirst leads to risk of dehydration and hypernatremia. Decreased renin, aldosterone, vitamin D activation leads to fluid and electrolyte imbalance. Drug clearance is decreased. The patient is now at higher risk for toxicity. Urinary system changes: decreased detrusor elasticity leads to decreased bladder capacity increased urgency. Weakened sphincters leads to incontinence. Females, the pelvic floor weakens, leads to urethral shortening and incontinence. Males, enlarged prostate leads to urine retention and weak stream. This is where males, usually with prostate, enlarged prostate, this is where males will go to the bathroom and they'll either have trouble starting to urinate, or when they urinate, it'll go in spurts. Like it'll start, it'll stop, it'll start, it'll stop. Assessment of the renal system. Patient history. Gathered demographics: age, sex, race, ethnicity. The Black and Latino populations have higher kidney disease risk. Acts about sudden onset of hypertension. Prostate in men over 50. Prostate symptoms in men over 50. Polycystic kidney disease in their 40s or 50s. Recurrent UTIs in females. Pregnancy-related conditions such as gestational diabetes, preeclampsia. Other key consideration: health disparities, income, insurance, transportation, language, and education all affect care access and compliance. Cultural or religious beliefs influence patients' comfort and understanding. Environmental exposures: toxins, hydrocarbons, heavy metals, and gases. Drugs: heroin, cocaine, meth. Contrast agents: iodine, gadolinium. Risk for kidney injury. Symptom questions: have you ever been told you had protein or albumin in your urine? Has your blood pressure ever been high? These are questions we need to remember with our kidney patients when they come in complaining of kidney issues. Travel, trauma, chemical exposure may suggest infection or damage risk. Health history assessment, nutritional history. Acts about diet and recent changes. Fluid intake, the type of fluid and the amount. Target is 2 liters per day unless restricted. Do they drink caffeinated drinks or high-calorie drinks? If so, how many and what types? High-protein diets, increased risk of kidney stones. Weight loss diets may require a referral to the dietitian. Taste and appetite changes may indicate uremia. Medication history. Document all prescribed over-the-counter and herbal medications that the patient takes. Pay attention to nephrotic drugs such as NSAIDs, acetaminophen, which is Tylenol, aminoglycosides such as gentamicin. Drugs for diabetes, hypertension, cardiac, hormonal, arthritis, psych, cancer. Creatine supplements can impair kidney function, so we have to ask them about that and educate them if they're taking it. Ask about drug changes or contrast exposures. Then we ask about the family history, genetic risks. Is it a history of kidney problems, including Bright's disease or nephritis or nephrosis? Polycystic kidney disease, PKD, autosomal dominant inherited. Then we want to ask about current health problems. Kidney disease affects all systems, so we need to ask about respiratory infections, joint or muscle pain, heart or GI problems. Focus on urinary changes. Color: rust color, brown, black, green, red, and cloudy. Odor: is it stronger or foul smelling? Output norm is equal to 1,500 to 2,000 milliliters a day. You know normal output is 30 mLs an hour. So do the math and see how much they supposed to have in a day. And then if it's less than that, we know we have to report it to the doctor. Symptoms: difficulty initiating stream, burning, weak stream, dribbling or incontinence, urgency or frequency, nocturia. Do they have pain? Is it in the flank, the pelvic, the perineal area? Perineal pain, pain in the flank, pelvic, or perineal area may indicate stones, obstruction, or infection. Renal colic may cause severe spasmodic pain radiating to the groin, the labia, or the scrotum. May be accompanied by hypotension, pallor, and diaphoresis. Uremia symptoms. Uremia symptoms: anorexia, nausea, vomiting, muscle cramps, pruritus, fatigue, and lethargy. We have to pay close attention to these. Anorexia is when a patient doesn't eat. So remember that they're not eating. So something may be going on with them. It may be due to something that's going on. Pruritus is when something in the body is causing them to itch. Lethargic. If they're lethargic, we have to think that their kidneys aren't filtering right. So we need to look at their labs. What is their physical assessment like? General appearance. You look for skin changes such as rashes, bruising, yellow tone. Do they have edema, pedal in the foot, peritibial, sacral, periorbital, around the eyes? What is their level of consciousness like? Do they have cognition changes, memory, attention span, concentration issues? What was their weight and blood pressure for the baseline? So we need to know what their weight and blood pressure was before they came to us, or before you saw them. Kidneys, ureters, and bladder. We're going to listen. Auscultation over the renal arteries for Brooks indicate renal artery stenosis. We're going to inspect. Look for asymmetry, swelling, discoloration in flank region, CVA area. Palpation is usually done by the primary physician. Right kidney may be felt, especially in thin patients. Transplanted kidneys can be palpated in the lower abdomen. Distended bladders may extend to the umbilicus. Do not palpate if tumor or aneurysm is suspected. Again, do not palpate if tumor or aneurysm is suspected. Percussion, dullness over bladder. If you hear dullness over the bladder, that means the bladder is distended. CVA tenderness suggests infection or inflammation. Flank pain, assess location, intensity, duration, radiation, and triggers. Where is it located? How does it feel? How long have you had it? Does it radiate to other spots? And what makes it worse is what a trigger is. Nursing safety and priority. Always report protein urea, hemuria, and glycosuria. Protein in the urine. Hematuria is blood in the urine. Glycosuria is glucose in the urine. Suspected bladder distension. If you suspect bladder distension, as a nurse, we can bladder scan a patient without an order. So please make sure you remember that. Use the bladder scanner if you suspect that your patient's bladder is distended, Or if you suspect that your patient is retaining urine, like when they go to the bathroom and they're not putting out. Use caution with palpation if a tumor or aneurysm is suspected. Diagnostic assessment. You're going to look at the GFR. Race is no longer included in the eGFR. I'm sorry. Race is no longer included in the eGFR equation. New creatine-based formula promotes high equality. Measure sodium and chlorine in urine. Normal 24-hour sodium should be 40 to 220 milliequivalents per day. Urine electrolytes, random sample, greater than 20 milliequivalents in a liter per liter is normal. Reflects hydration and salt intake. Measures solute concentration in urine. Normal range 50 to 1200 MOSM per kilogram. Urine osmolarity. Average fluid intake 300 to 900 MOSM per kilogram. Increased osmolarity equals concentrated urine, low water. Decreased osmolarity equals diluted urine, high water. Bladder scanner. Non-invasive, measures bladder's volume. Select correct sex icon. Female icon subtracts uterus volume. Use gel above pelvic bone. Scan towards coccyx. No prep needed. Explain sensations and the process to patient. KUB X-ray. X-ray of the kidneys, ureters, and bladder. Shows size, shape, stones, strictures, and calcifications. No prep or follow-up care needed. Shows 3D structures, tumors, mass. I'm sorry, this is a CT scan with or without contrast. Shows 3D structures, tumors, mass, vascularity. Contrast, iodine base, IOHEXOL. Then there's another one, promenade, PROMIDE. Then there's IODIXANOL. Y'all know I'll be jacking words up, so I'm spelling them. Check if patient needs to be NPO based on a hospital policy. Encourage hydration to flush dye. Contrast-induced acute kidney injury. This is what they're at risk for. Increase the risk in elderly, dehydrated, chronic kidney disease, diabetes, heart failure, or hypertension. Metformin users stop 24 hours before the test with contrast. Hold 48 hours after contrast use. Check kidney functions before restarting the metformin. Nephrotoxic risk factors. Avoid contrast in patients taking nephrotoxic drugs such as NSAIDs and some antibiotics. Ensure fluid intake of 1 liter or urine output of 1 to 2 milliliters per kilogram per hour times 6 hours post contrast. So when they are giving contrast on these tests, they have to be their intake and outtake has to be monitored strictly, because we want to know if they're getting ready to contrast. Also with contrast, Risk factors for contrast reactions. Previous reactions to contrast, hives, or bronchial spasms, asthma, hay fever, food or drug allergies, especially seafood, eggs, milk, and chocolate, dehydration, renal impairment, nephrotoxic drugs. We talked about them. Contrast media and kidney injury. Hydrate before and during contrast use is critical. Older adults, especially over 60, should be evaluated for renal function prior to getting contrast. Gadolinium based agents, MRI. Avoid if GFR is less than 30 mLs per minute or creatinine is greater than 1.5 milligrams per deciliter. Drug alerts. Metformin. Hold for contrast studies. Risk of lactic acid. Right? That's a safety priority. Contrast agents. Check for prior allergies, asthma, or impaired renal function. The gadolinium for MRIs, avoiding renal impairment. Radioisotopes, avoid renal scans in pregnant women unless absolutely necessary. Furosemide or captopril may be used during renal scans to improve visualization. Diagnostic key term consideration. CT and contrast. Again, we checking allergies, renal function, whole metformin. This is in the boxes. MRI or MRA, contraindicated with metal implants. Check renal function because they got to give them that medicine, the gadolinium. Ultrasound, non-invasive, safe, full bladder needed. Renal scan, use radioisotopes, safe in contrast allergies, avoiding pregnancy. Renal arteriography, invasive, uses IV contrast, check for bleeding risk. Cystoscopy, cystourethoscopy requires consent. The patient needs to be NPO. They need to have a bowel prep. You watch for bleeding, infection, and bladder puncture. Cystogram, VCUG, catheter is needed. Contrast instilled directly into the bladder. Retrograde procedures performed with cystoscope, no systemic contrast exposure, and we're going to monitor these patients for infection. Other diagnostic assessments, cystometrography. The purpose is to assess bladder wall muscles, the detrusor function, capacity, and voiding reflex. The nursing action, patient education. Explain the procedure needed for temporary catheter. Explain the procedure and the need for temporary catheter. Monitor residual urine before and after voiding. Watch for infection signs, fever, changes in urine. Urethra pressure profilometry. Evaluates pressure in the urethra, helps diagnose incontinence or retention. Temporary catheter with pressure sensor, monitor the patient for UTI symptoms. Urine stream testing, assesses ability to start and stop urine flow. Pelvic muscle strength, provide the patient privacy. Clean perineal area after test. Explain the electromyography, EMG, Measures perineal muscle activity for continence evaluation. Explain mild discomfort. Electrodes in rectum or urethra. Give analgesic after procedure. Infection risk is a key safety priority for all studies involving urinary catheterization or instrumentation. Kidney biopsy. Um, Patient preparation. We want to explain the purpose of this procedure. Diagnosis of renal issues. Sign consent. The patient needs to be NPO 4 to 6 hours. Pre-procedure. Check labs, platelets, APTT, PT, bleeding time, control hypertension, treat uremia, may need dialysis or transfusion. During procedure, percutaneous biopsy with sedation. They need to lie in a prone position. They'll get local anesthesia. Patient holds breath during needle insertion. A sample is sent for pathology. Major risk is bleeding. So bed rest is a must. Supine with back roll for 2 to 6 hours. Post-procedure, monitor the patient's blood pressure, the urine output, the dressing, the hemoglobin, and the hematocrit. Watch for flank or back pain with hypotension. I'm sorry, let's repeat that. Watch for flank or back pain plus hypotension may believe to be internal bleeding. Hematuria is common, resolves in 2 to 3 days after a biopsy. Avoid heavy lifting, straining 1 to 2 weeks. Signs of internal bleeding, flank pain, decreased blood pressure, decreased urine output, shock. Hematuria, microscopic, gross blood is expected, but not clots. If they have blood clots, that's abnormal. It needs to be reported. And that's it for this chapter as well. You have some questions when you go through here on these slides. So go through and do the questions and reach out to me via Remind, because I don't check my emails on the weekend. So via Remind. And if you have any questions, if it's, make sure it's early during the day and I'll get back to you.